I have no disclosures. So first off, I'd like to posit the fact that for the majority of countries, breast cancer in young women is a relatively rare disease. Even in the developing world, where it seems to be more common, probably because of an absence of as much postmenopausal disease due to competing risks for mortality and morbidity. Breast cancer in young women, as you can see in this graphic, only occurs in approximately 6 to 7% of women of breast cancer in at least most Western countries. Nevertheless, breast cancer is the leading cause of cancer-related deaths in young women, and you can see here the 5-year relative survival rates updated as of this year from SEER data polled as of 2009. These are improved from several years ago, and I think they now incorporate the use of adjuvant trastuzumab, although you can still see that there is a large differential between younger and older women. Here you can see demonstrated from Carrie Enders and colleagues that even when you look at women who are still young but not as young, that is on the left graphic, women who are 40 to 45 compared to women less than 40, there is a big differential in terms of disease-free survival by age, which corresponds to an overall survival difference. And when you look on the right panel of women who are under 40, there is no clear difference within those subgroups, and you again see the split for the over 40 and under 40, also all still premenopausal and obviously still young, but not very young. Breast cancer in young women is therefore different. There are disease differences in that young women present with more advanced disease at diagnosis, and that's been documented over and over again in many data sets. And this may be due to delays in diagnosis, thus time, and there are many reasons for that, and more aggressive biology. More aggressive disease is conventionally found in younger women. There are also significant host differences. The host differences include most notably genetics, the hormonal milieu. Young women are definitively more premenopausal on average, or longer to be premenopausal, and may not become postmenopausal with chemotherapy. Young women clearly have different psychosocial issues, and fertility concerns is one of the biggest. I always group that in psychosocial, but really it's a little more than psychosocial and biological. And I'll talk more about that later. We showed in our group the pathologic features and biomarker expression among young women in our Young Women's Breast Cancer Study, which is a prospective cohort study, and this was for the first 400 or so patients. And we were looking to see if there were differences in the phenotype of tumors and the features for younger women, looking at different subgroups of young women. You can see across the top, 40 and under, but we had them subgrouped by less than 30, 31 to 35, and 36 to 40. And while we only found, as you can see with the star, tumor necrosis was increased in the very young, and we're going to do more work to look at what's going on there. Maybe that has to do with the disease associated with the BRCA mutations. What was striking about this data set was the differences between the young and the old in terms of the type of disease they present with. So, for example, among ER positive, you can see that only about 60% of young women present with ER positive disease in contrast to older women. HER2 positive, it does appear, again, this is not population-based, that a substantial proportion, higher than you would expect to see in all women with breast cancer, present with HER2 positive disease in young women. And then most strikingly, about 2/3 of breast cancer seen in young women in our cohort present with high-grade disease. No wonder they do worse on average, especially when they present with more advanced disease due to delays along with the biology. Now, this was the first population-based data, which I'm showing you here in the bar graphs, from the California Cancer Registry and SEER data to depict the differences by age group, including HER2 data that's been published that I can find. And you can see here demonstrated that in the very young women in the bar on your left, there is a substantial proportion of hormone receptor positive HER2 new negative disease in the blue, but the triple negatives in purple are a very, very large group. And then the HER2 groups, HER2 positive, hormone receptor positive in red, and HER2 positive and hormone receptor negative in green are also quite large and statistically larger than older young women, as well as women over 50. This has also been shown in other data sets, and similar to what's been seen in groups like the California Breast Cancer Study, as well as the Carolina Breast Cancer Study, there is also a relationship between age and race in that women, especially of African American descent in America, as well as Hispanic descent, tend to have more higher risk triple-negative breast cancer, and that obviously contributes to some of the disparities we see in at least the US population. So, seeing the differences in the subtypes that young women tend to present with, the question of whether or not there's a molecular signature that's different for breast cancer in young women has arisen. And investigators at Duke and then now UNC have looked at this, and initially a comparison of breast tumor gene expression differences by age, looking at women less than 45 or older than 65, was provocative. They initially found several thousand genes differently expressed between age-defined classes, and yet when they controlled for the significant clinical pathological features, including intrinsic subtype and grade, there was only one gene difference between the groups. And then they tried to validate their findings in another data set. And again, once that they controlled for the obvious things that we now know need to be controlled for, there were 0 gene differences. So investigators are still looking to say, is there something unique that is expressed in young women's tumors, either genetically and or epigenetically or otherwise? And very recently, as presented by Sybil Loibel at the San Antonio Breast Cancer Symposium, we saw some, again, very provocative data suggesting that PCR rates, especially in young women, as you can see in the less than 35 group in purple, compared to older women, and the age groups go up as you go from left to right, are much greater in young women. We've seen this clinically, and they are very different depending on which tumor subtype you look within. And you can see the different subtypes, and the differences were most striking in the triple-negative group. So this is very provocative, and I think many investigators are now looking into what's different about the triple-negative breast cancer, or again, the mix of disease developed by younger versus older women for hopefully someday future targeted therapies. We looked as a group at whether or not age was still a prognostic factor in one subgroup, the HER2-positive subgroup, and we found, looking at the HERA data, and this is a step analysis according to age was neither prognostic nor predictive for early recurrence in the HERA trial. So clearly, something is going on with age, but it very much appears to depend on the tumor subtype. So when you compare apples to apples in terms of prognosis, not so clear that if you have a HER2-positive tumor and you control for everything else, you're going to do any worse as a young woman than as an older woman, again, assuming everybody gets appropriate therapy, but maybe you do differently if you had a luminal A or a luminal B, and we certainly need to do more work to look at this, and a lot of investigators are doing such, so stay tuned. Speaking of luminal A and luminal Bs, there has been quantification of gene expression looked at by age, and these are data from Genomics Health, and you can see here that the average age of recurrence score is slightly higher in the younger age groups, but there's a wide range of observed scores in all age groups, and remember, these are select patients. So while there are over 5,000 patients in this data set who are under age 40, these are all patients that were selected to have their tumors sent to Oncotype or to Genomics Health for the Oncotype. So you have to take all of this with a grain of salt in that there's a whole population of patients for whom Oncotype has not been sent. So features were concerning perhaps that they didn't bother even with hormone receptor positive node negative breast cancer. Further, this is very limited. There's no outcomes data here, and there were very limited outcomes data, particularly for the under 35 set from the validation studies. But clearly, as you heard from the two prior speakers, Drs. Goss and Davidson, not all young women need chemotherapy, and I would only point you to the ABCSG-12 outcomes, which were outstanding, and we all know that only about 5% of those women received any chemotherapy, and the majority of the treatment was hormonal therapy. What about local therapy decisions in young women? Well, it's been documented over and over that young age is associated with increased risk of local regional recurrence in general. But again, when you compare apples to apples, so young women getting mastectomy versus young women getting breast conservation, what we've seen now in a number of studies is that survival is similar in young women, whether they have breast preservation or a mastectomy. Thus, age is not a contraindication to breast preservation. Of course, one does need to think about genetic future risk, and that may play into decision-making, as well as patient preferences and cosmetics, which are also a big issue for all women with breast cancer, but young women in particular. We do also know that the effective age appears to also vary by tumor subtype, similar to what we've seen, as you might expect, in terms of systemic recurrence. So, is young age still an independent predictor of a prognostic indicator? My answer would be maybe. I think the current studies are limited. There are still relatively few data with women under the age of 35, although that's increasing. And there are little data regarding tumor-host interfaces, most importantly, whether a young woman enters premature menopause. And again, the data are increasing. Future research is clearly warranted, and the differences may disappear by age as we do better tumor subtyping. So currently, we do use age to direct therapy to some degree, especially considering the competing risks, because most younger women won't have cardiac problems or others, and we do worry a bit more when we see a younger patient because of the historical risks. This begets the question of, should treatments be different? Well, we all know that we need to target the tumor, but I would argue that in younger women, we need to target the tumor in more consideration of the host. Someday, we may be targeting the tumor, and more benefit may come for younger women as we develop treatments where BRCA1 or BRCA2 or other genetic factors may influence our adjuvant treatment. I know that's all on the horizon, and that may more differentially help younger women who are more likely to have a genetic predisposition to having developed their breast cancer. And then, of course, as you just heard from Nancy Davidson, we don't know the optimal hormonal therapy for young women, and we await SOFT in particular, which I think will be a treasure trove of information, not only because of the primary outcomes, but because there are a number of ancillary studies that will address not only will it improve how they do, but at what cost, both psychologically and a number of other outcomes. But we do know, even if we can spare some young women chemotherapy, there is, on average, a large benefit from chemotherapy in very young women. These are from the older Lancet publication of the overview. And in young women, while the groups are small, there is a clear improvement in overall survival and recurrence. We also know, as you saw earlier from Nancy Davidson, that tamoxifen for 5 years is associated with substantial improvements in disease-free and overall survival. And there's no evidence of heterogeneity in the effects of tamoxifen by age or by the prior administration of chemotherapy. The ATLAS data, as you just saw presented by both prior speakers, suggests that the risk-benefit ratio may be most favorable for young women in that they don't have an alternative, many of them, because many of the very young won't become postmenopausal with their chemotherapy. And then on top of that, they're much less likely to develop endometrial cancer. So younger women are the ones that we're really thinking about offering extended endocrine therapy with tamoxifen based on the ATLAS data. But as we recommend this for young women, and I think of it as the cancer has condemned many of them to this, especially with high-risk disease, we need to more think about how young women have much different or accentuated by young age long-term late effects. First of all, they have very premature menopause, either through the chemotherapy or ovarian suppression, and this has implications for infertility, family planning, bone health, cardiac and cognitive health, as well as potential weight gain. And then they have a greater implications for second cancers, which begets questions about genetics, both medical and psychosocial concerns, as well as screening issues for these young women, which, in the interest of time, I won't get into the details. And then what's been shown over and over again is that there's an increased risk of psychosocial distress for young women, both at diagnosis and in long and short-term follow-up. Why? Well, first of all, as I've demonstrated, young women are at higher risk of disease recurrence, and they receive, on average, more aggressive therapy because of this. On top of that, young women are more likely to be concerned about role functioning, they're more likely to be raising young families, starting a career, trying to get through education, and then issues like beauty and attractiveness, sexual functioning, and then, of course, family planning and fertility are of paramount importance in the young population. I want to focus on one issue because there have been some new data since the last Gallen. ASCO recommends that we, first and foremost, assess the risk of infertility with our young patients and then communicate this risk with the patient and understand the patient's preferences about future fertility for all adolescent and young adult patients. And for women with breast cancer, there are a number of options for fertility preservation strategies. As of 2012, the strategy using ovarian cryopreservation is considered no longer experimental. The techniques have been perfected enough that there is a suitable number of babies that have been born to date by freezing eggs and then having in vitro fertilization later, that they have now joined a standard option for fertility preservation. Now, of course, this is not available widely, and there are costs and other barriers associated for a young woman who's facing a new diagnosis of breast cancer, but I think it's good news because there are more options. Cryopreservation of ovarian tissue on the far right remains very experimental, although the techniques are improving. And then ovarian suppression is something that's increasingly been studied, and there have been a number of publications that have come out over the last few years, especially since the last St. Gallen. Here's a table I borrowed from my colleague Natalie Turner, and this is from a publication that's under review. And what this shows, and I won't have you all memorize it, and I know it's hard to read, but there are 8 randomized controlled trials that have come out or will come out soon that have looked at the use of a GnRH analog through chemotherapy, and they are mixed at best. The one that's pending is the SWOG 0203, or the POEMS trial, which is the largest, and focuses on women with triple-negative breast cancer, and therefore it removes the issue of whether or not tamoxifen interferes with the ability to tell whether or not a woman remains premenopausal and therefore possibly still fertile. So at this point in time, I would say that I would not use suppression of the ovaries as as a definitive strategy to prevent infertility. I think the data are just not there yet, but one can consider using this if other options are not feasible in a motivated patient. So I just want to show you one last study that came out since the last St. Gallen, and this is a retrospective case control by colleague Hatem Azim from Belgium, and they looked at, well, okay, if we preserve fertility or we don't put people into definitive premature menopause, is this safe? And if they go on to become pregnant, how do we feel about that? This has been a long controversy and concern for women who are interested in future fertility and their providers. And they looked at pregnant cases, and most importantly in this data set, they knew the ER status of all the patients, and they used 3 controls for every pregnant case. And what they found, focusing on women with ER-positive disease, because that's where the bulk of the concern has been, will this, having a baby after breast cancer, increase the risk of recurrence? And fortunately, the data are reassuring. You can't completely remove what's called the healthy mother bias, because these are not randomized data. Women who choose to get pregnant may still be healthier and more able to get pregnant. But again, these are reassuring for our patients as we discuss this important issue. And in this data set, early pregnancy apparently was not even detrimental within the first 2 years compared to women who did not get pregnant. Again, reassuring, but always a dicey subject for young patients who have an uncertain future, particularly with high-risk disease. In light of this, there's a planned international collaboration for a study to look at taking a break in tamoxifen for very young women to try to become pregnant. I think this will be increasingly important as we now consider 10 years of adjuvant therapy, and therefore for a woman diagnosed at 28, you're now saying you can't get pregnant for 10 years. So I think this study will be very important, and please contact myself or Olivia Pagani, who's leading this, if you're interested in hearing more about this, which is in the works. Finally, I think increasing attention to issues related to breast cancer in young women are going to take us places. The National Cancer Institute in the US and the CDC have all gotten in on the act, and there's even legislation now called the Early Act, which was part of the Obamacare or healthcare reform, to look at not only how we can help protect younger women and help them understand their risks better for women who come from high-risk families, but also to develop educational and supportive care interventions for women when they're diagnosed because of their unique needs at a young age. And I'm happy to say that the second BCY, or Breast Cancer in Young Women, will be held in Tel Aviv, Israel in November 2014, so please sign up if you're interested. So in conclusion, targeting the tumor in consideration of the host, including psychosocial concerns, is most prudent for both young and older women. And while the experience of cancer differs by age, young age alone is of increasingly limited value as a prognostic indicator. I don't think we're throwing it out, but I think we need to reconsider that conventional stance. And increasing attention is leading to focused research and more comprehensive care approaches that may improve outcomes in this vulnerable population. Thank you.